Good morning, everybody, and thank you for joining the CancerBridge webinar today with Dr. Florbakis. The topic will be the relationship between human papillomavirus and gynecologic cancers. We're going to give a few more minutes because everyone is starting to join, and then we'll get started. Thank you. Good morning. We're just going to wait a couple more minutes for some more people to be able to join the webinar. Thank you. Okay, good morning, everyone. We're going to go ahead and get started. This is Cindy Groniger, and I just want to take a few minutes to allow participants to join the webinar with Dr. Florbakis. So we just want to thank everyone for joining us today. In recognition of National Cervical Health Awareness Month, Dr. Florbakis will address the connection between HPV and cervical cancer, as well as the importance of the HPV vaccine in cancer prevention. She will also discuss strategies for how to discuss HPV with your children. Before introducing Dr. Bacchus, I would like to take a few minutes to remind you of the CancerBridge service provided by your employer. CancerBridge is a cancer-focused navigation service that provides you or your family members with immediate, one-on-one personalized access to a physician such as Dr. Bacchus, who is an expert in your specific type of cancer. In essence, we provide immediate expert guidance at a time of uncertainty. Why isn't it going? Calling CancerBridge is a very simple process. You just call the toll-free number. The call is answered immediately by an oncology nurse who will triage the call, answering your questions on your type of cancer and provide you the opportunity to speak to an expert and/or connect you to the right resource. After a call with a specialist, the oncology nurse will follow up to make sure all of your questions were answered and help you navigate through the cancer landscape. CancerBridge provides you and your family members with someone knowledgeable who will listen, rapid access to an expert in your specific cancer, and helps you obtain a broader understanding about your cancer. We provide guidance on your next steps and avoiding mistakes, navigating you through the healthcare system, as well as providing immediate answers during a time of crisis. CancerBridge is not only for you as an employee, but also includes your immediate family members. All those eligible include your parents, parents-in-law, spouses, partners, children, and siblings. When calling CancerBridge, please have the employee identification number available. Some important factors to think about on why a typical general practitioner or oncologist cannot provide the service that CancerBridge provides. Our research shows that there are over 200 types of cancer, and the number continues to grow. Community doctors are generalists with a basic knowledge of the most common cancers and don't have easy access to expertise like Dr. Bacchus and her colleagues can provide. Our cancer experts are each invested in one particular cancer type. They know all the presentations and the latest best treatment for that cancer, and they evaluate and treat only patients with that cancer and advise the community oncologists on that cancer. More importantly, they perform and publish research, lecture around the world, which enables them to teach medical students, residents, and fellows on their specific type of cancer. Our experts know and network with other experts across the world who specialize in the same type of cancer. To learn more about CancerBridge, please visit our website at www.mycancerbridge.com or speak to your Human Resources Department. Throughout the webinar, if you have any questions for our Q&A, you can ask them through the questions panel in GoToWebinar. If you think of questions after the Q&A is over, you can email them to questions@mycancerbridge.com. A recording of the webinar will be posted to YouTube and the CancerBridge website in the next few days. Now I would like to introduce Dr. Flora Bacchus, who is an associate producer in the Division of Gynecologic Oncology at the Ohio State University Comprehensive Cancer Center, James Cancer Hospital, and Solove Research Institute, where she is also a member of the Cancer Control Program. Her research focuses on reducing the incidence, mortality, and morbidity of gynecologic cancers. In addition to being widely published, Dr. Bacchus is also rated in the top 10% of physicians in the nation for patient satisfaction in 2017 and listed on the 2017 National Best Doctors list. It is my pleasure to introduce Dr. Flora Bacchus.
Thank you for that kind introduction. I hope everybody can hear me and also see my right screen. All right, we'll go ahead and get started. So as was already introduced, we'll talk about cervical cancer as well as the human papillomavirus today. And so to start with, I figured we should probably start with some anatomy, as not everybody may recall this from their early biology years in school. So here is the women's reproductive tract, the vagina, the cervix, which is the lower part of the uterus, with the body of the uterus, the ovaries, and fallopian tubes. So a few statistics. Worldwide, cervical cancer is the fourth most common cause of cancer, with over 500,000 new cases globally and almost over 250,000 deaths. It is the second most common cancer in the developing world after breast cancer. In the United States, the incidence has decreased and is now the 12th most common cancer. But still, there are over 12,000 new cases each year and over 4,000 deaths. And this is the estimate from 2017. Median age of diagnosis is 51, and there's a very small percentage of patients who develop cervical cancer at a very young age, such as less than 21. Overall, cervical cancer is very well treatable and curable. And as you can see from this survival course, on the left, on the y-axis, you can see the percentage of patients surviving. And on the x-axis, you can see the years after diagnosis. So for the earlier stages, stage 1A, 1B, 1A2, 1B, those are highly curable and most of those patients will live. But as the stage progresses, you'll see that the survival curves drop off, where now for stage 3, for 5 years, we're getting around to 50% of patients who survive 5 years. So what are risk factors for cervical cancer? Environmental developing countries have a higher incidence of cervical cancer, and that has mostly to do with access to care. Habits such as tobacco. Tobacco is one of the main risk factors after HPV, non-Caucasian race. Certainly multiple partners, early intercourse can get you exposed to sexually transmitted diseases early on. Screening, so lack of any or recent pap smears increases the risk for cervical cancer. There are certain medications also, such as DES, which is a medication that used to be given to women to increase fertility, or women who had multiple abortions in the past. But you don't use that medication anymore, and it's a risk factor of a very particular and rare kind of cervical cancer. Infectious, the human papillomavirus is the main risk factor, and we'll talk a little bit more down the road in this presentation as well. Immunosuppression, such as HPV, patients with a transplant who are on taking immunosuppressive medications, patients who have autoimmune diseases that need chronic steroid use are also at increased risk, as these cannot clear their HPV infection as easily. So what is the human papillomavirus? It's certainly the major role in cervical cancer and is involved in more than 95% of cervical cancers. HPV 16 and 18 are the two highest risk ones. 16 is related to squamous cell carcinoma. HPV 18 is related to adenocarcinoma. So those are two different kinds of cervical cancers. And these two together cause over 70% of the cervical cancers worldwide. It is a non-enveloped DNA virus, but fortunately the minority of infections lead to cervical cancer. Like I mentioned before, smoking and immune suppression allow this virus to grow more rapidly. And HPV infections are not just a problem for cervical cancer. Each year in the United States, 14 million people become infected with HPV. So this is not a rare event. Each year, over 17,000 women and over 9,000 men are affected by HPV-related cancers, such as genital warts, which are really not cancers, but can still cause a lot of symptoms and morbidity. Cervical cancer, penile cancer, mouth and throat, or oropharyngeal or tonsil cancer, anal cancer, vulvar cancer, and vaginal cancer. All of those are also related to HPV. This is an interesting study, and what these researchers did in this study, they took 600 HPV-naive women, and they start testing them periodically. So what you see here is a cumulative infection incidence of HPV infection. So at time point 0, these women did not have HPV and had not had intercourse. Then as their college years progressed, About 2 years into it, 2 years after first intercourse, approximately 40% had already been exposed to HPV. And over life, this actually increases to 80%. So over life, more than 80% of women will get exposed and infected by HPV at some point. Fortunately, 80% of HPV infections are transient. So the gradual development of the cell-mediated immune response, which we need to fight the virus, develops with time and as we mature, and that allows us to clear many of these infections. The majority, 70% of new HPV infections are cleared within 1 year and 91% within 2 years. And overall, the median duration of infection, so how long somebody has detectable virus present, if you would take a sample, is approximately 8 months. However, certain HPV types are more likely to persist, such as HPV 16 and 18, and those are also the ones that we just heard about that are more aggressive and the major causes of cervical cancer. If you are immune competent, so you have a good immune system, then CIN3 or precancerous lesion is cleared in about a third of cases. So this is another interesting study where these researchers took over 20,000 women. And they looked at these patients who were positive for a certain type of HPV and then looked at the development of precancerous cells such as CIN3 or actual cancer. And so what they found was if you were positive for HPV 16, which is this orange line all the way at the top, after 10 years, 17% of these women would develop either precancerous cells or cancer cells. If you had HPV 18, you would also have a higher risk of developing these cancer or precancerous cells, but to a level of about 13%. Now, there's other oncogenic types other than 16 or 18, so that means that they are still at increased risk of causing cancer. But those other types, other HPV types with other numbers, and we'll see a little bit more about that, like 31, 35, the risk with those is approximately 3%. Whereas if you don't have the HPV virus, your risk of developing cervical cancer or precancer cells is very low and a risk of 1%. And the HPV infection is followed by the peak in cervical cancer risk and incidence. So here's the HPV prevalence. So as you see in the college years, that number goes up in the 20s and 30s, then most women will clear their infection. But if you do not clear it and you have persistent infection, you'll see the rate of cervical cancer rising with a peak in the 30s and 40s. So what are some signs and symptoms of cervical cancer? Here you see a pretty disgusting picture, but that's kind of what it looks like if you look at the cervix. So where it's normally nice and smooth, now you see this kind of fragile and friable tumor sitting on the cervix. However, you can't really see this unless you have a speculum examination and a pelvic examination. So most of these tumors are actually asymptomatic. You may have an abnormal PEP test or cervical cytology. You may present with vaginal bleeding either after intercourse or sometimes during intercourse. Bleeding after you've already gone through menopause, so that should never happen. Or if you're still having periods, then you could also have bleeding in between your cycles. It may also present with vaginal discharge, and sometimes that can be a lot of vaginal discharge, and it's often malodorous. And if it gets really severe and more advanced, you can develop flank pain, leg or back pain, and even leg swelling from the tumor growing out to the pelvic sidewalls. So the way we diagnose it, other than for a screening, is with this instrument that is called, this microscope instrument, which is called a colposcope. And with that, we can do a speculum exam where we look at the cervix, but then look at it in detail with the microscope. And we use these tools to take biopsies. So cervical cancer diagnosis can be done with a pelvic examination that can be done in the office when you see your gynecologist or family doctor or primary care physician, and sometimes in the operating room if you cannot tolerate an exam. It is clinically staged, meaning that by our exam we can determine what stage it is, and this is done because globally many countries do not have fancy equipment such as PET scans and MRIs and all of those things. So we use colposcopy, the microscope, and then we have to perform a biopsy. So the biopsy actually gives us a diagnostic test. It cannot be diagnosed from a PAP. The PAP is a screening test only, and it will give us some cells. But if you have an abnormal PAP, it always needs to be followed with a more detailed exam and biopsies. So if we then look at cervical cancer staging, this is a picture of early stage cervical cancer on your left. This is a stage 1B1 where the tumor is visible, but it's less than 4 centimeters on the cervix. And when it is greater than 4 centimeters, then it's a 1B2. And as we just mentioned, if it becomes more of an advanced stage, it involves the cervix. And what cervical cancer does, it doesn't necessarily grow up, but it grows out to the side walls. And so it goes into these tissues surrounding the cervix called the parametria, and then can grow out all the way out to the side walls where it can start blocking the ureter, which is a tube that comes from the kidney to the bladder, and that's how the kidney drains urine. And so that can cause something called hydronephrosis or a swollen kidney, and can grow out to the pelvic sidewall here, and it can start causing more symptoms. So how do we treat cervical cancer? Well, that depends on the stage of diagnosis. If the cancer is early stage, meaning only the cervix is involved, such as with stage 1A and 1B, we do surgery with a radical hysterectomy and lymph node dissection. So a radical hysterectomy is a little bit different from a regular simple hysterectomy that you may have for fibroids or abnormal bleeding or something like that. The radical hysterectomy involves taking the upper part of the vagina and the tissue surrounding the cervix, like we saw in the other picture before, these parametria, to make sure that there's no cancer cells that have already spread out to the sides. It does involve the uterus as well, as the cervix is attached to the uterus. And in most of the cases, we can now do those operations through small incisions. So this is just a general picture of something that you may have heard of, robotic surgery, where the surgeon sits at the console and sits remotely from the bed. The patient is on the bed here. The robotic arms are docked and attached to the ports that we have placed, and then there's an assistant at the bedside. So the surgeon still controls all of these arms, but doesn't stand right at the bedside, but sits right here. Sometimes cervical cancer develops when women are still in their childbearing age and have a desire for future fertility. 10 to 15% of all cervical cancers occur in women during the reproductive years. And in that case, if it's still a small tumor, a radical trachelectomy and lymph node dissection may be an option. A radical trachelectomy basically means that you remove the cervix only, meaning you remove this part only, and then reattach the vagina back to the cervix, where we suture that back together. Certainly that comes with risks, and in general, you must have a desire for fertility preservation, a small tumor, and no evidence of that the cancer has already spread to the lymph nodes, and that there's no cancer cells here at this upper border between the uterus and the upper cervix. This can be done, but certainly if you do not have a cervix, when you do get pregnant, it does put you at risk for preterm labor and preterm delivery. And oftentimes there'll be a special kind of suture called a cerclage placed around the bottom of the uterus to try and keep the uterus at least closed as long as possible. If you have more advanced stage, so a stage 1B2, when there's a bigger tumor and when it spreads outside the cervix to the upper vagina or the tissues around it, the parametra, to the sidewall, or even into the bladder or rectum, in that case, surgery to remove the primary lesion or hysterectomy is not indicated, and it is treated with radiation therapy along with weekly cisplatin, which is called radiation sensitizing. So basically, we give chemotherapy, a low-dose chemotherapy along with it every week to make the radiation work better. And so the way that works is that the patient lays in a radiation machine that's called an X-ray generator. So it's kind of like an X-ray, but it takes a little bit longer and stronger beams, and then gets the radiation, and we use this external beam radiation to radiate the pelvis. And then after that's done, and that takes about 5 to 6 weeks, then we also give internal radiation, where there's a radiation device placed directly into the cervix and against the cervix that can give an extra high dose of radiation to the cervix. So if radiation is needed, it should always be comprised of external beam radiation, which is a daily radiation that's usually 5 weeks, and then the internal radiation, which is usually 5 treatments over the course of 2 weeks. If the cervical cancer has spread, so gone to other organs, or the cancer has come back after an original diagnosis, it is treated with chemotherapy. Obviously, we do our best to treat it as well up front when it's first diagnosed, because once the cancer comes back, it is usually not curable anymore. We can treat it, but even with the best chemotherapy that we have currently, the median survival, or where 50% of the patients are still living, is around 18 months. So there's a lot of room for improvement. And certainly, therefore, we're trying to develop novel treatments and have many of our patients participate on clinical trials to study these new treatments also. And certainly in these trials, there is no placebo. These are real treatments for patients that have not responded to the standard of care treatment. So immunotherapy is obviously a hot topic and very effective for certain types of melanoma, for certain types of lung cancers, certain endometrial cancers, and we're also seeing some responses in cervical cancer. The most recent trial reported a 17% overall response rate. That means that 17% of the patients who received immune therapy saw their tumor decreasing in size or disappearing. So we see some responses, but not everybody responds yet, and we don't really know yet how to determine which patients are going to be the ones who are going to benefit from this most. The other thing that is kind of new and developing are tumor vaccines, where we take a piece of the tumor, then take that out of the body, use these tumor cells to develop a vaccine against those tumor cells, and then put that vaccine back into the person's body. So you really make a vaccine. We try and make a vaccine against your own body. That is done at certain places around the country, and there are a select number of trials open to do these type of trials. Obviously, those are high-risk trials, but we also have seen some, certainly at the National Cancer Institute, or NCI, they've seen some really nice responses. The one exception to what I mentioned before, where if the cancer comes back, it is usually not curable, is when the cancer comes back right in the middle of the pelvis, and if that is the only area of cancer. In that case, there's still a potential for cure, but that would require a pelvic exenteration. And a pelvic exenteration has an overall survival of about 50%, meaning in 50% of the time, patients are cured, and in 50%, it still comes back in another spot. A pelvic exenteration, we don't do that lightly because this is, for example, a sample, and what you're looking at here is all the way at the top. This is the bladder. attached to the vagina in the middle with the uterus and cervix, where you see this big tumor, and then it is attached to the rectum. So really all the pelvic organs have to be removed: the bladder, the vagina, the uterus, the cervix, the rectum, and then we have to reconstruct a new vagina, a new bladder from a piece of bowel, and a colostomy. And sometimes that's done with one ostomy and sometimes with two. So these are very high-risk surgeries, but when there is a potential for cure, these may be worth it for select patients who can tolerate a surgery like that. So we've talked a lot about cervical cancer, but what can we do to prevent cervical cancer? Well, there's two things really. The first thing is screening. 50% of the women who develop cervical cancer never have had a pap smears, and 10% of the cancers occur in women who have not been screened for over 5 years. Vaccination is the second thing that we can do, and approximately 65% of eligible girls were vaccinated in 2016, and 56% of the boys. That's a lot better than it was a few years ago, but only 43% of the boys and girls who started the vaccine series also completed the series. So back to cervical cancer screening. What is the goal? The goal is to detect precancerous cells. So we don't want to detect it when it's already developed into a cancer. We want to see these cells when they are still precancerous and haven't grown into a real cancer, so that we can remove the precancerous cells so they don't develop into a cervical cancer. And using the Pap test, cervical cancer incidence has declined by more than 50%. So this is a very effective method. In 1975, the incidence was almost 15 on 100,000 women years, and it has gone down to 6.5 on 100,000 women years in 2013. So certainly can allow us to detect a cancer early also. So that is what it is, and it has proven to reduce the mortality of cervical cancer by diagnosing early so that it can be treated and hopefully a surgery can be completed. So when we talk about those precancerous cells, cervical intra-epithelial neoplasia, or CIN, or precancer, those are all kind of similar things. This means that there are some abnormal cancer cells that start here, and they work their way up through the whole layer of the cervix. And so this is kind of an early stage, or an early precancerous lesions that then can become more extensive and develop into the closest stage to cancer. So you can see that these abnormal cells get in more thicker layer of the surface of the cervix until they become actually a cancer. And here they become an invasive cancer when they go through this nice basement membrane that separates just a superficial layer from the underlying cervix. When they start growing through that layer, it becomes an invasive cancer. So that's what we want to avoid. We want to take this off before this happens. So if you have an abnormal Pap test, that's usually with high-grade cells on the Pap smear, it would be recommended to do a colposcopy and biopsies if any abnormal areas are seen. If those biopsies then confirm that there's truly high-grade precancerous cells, or CIN2 or CIN3, then a loop electrode excisional procedure, or LEEP for short, is recommended, or cold knife conization. So what we do with that is really take a cone sample from the cervix, and this is usually can be done in the office or sometimes done in the operating room, where you take the outer layer of the cervix and a bigger biopsy from the inner layer of the cervix also, but leaving normal cervix on the outside. And this is to remove the precancerous cells so it doesn't develop into cancer. And again, also ruling out that there's already a cancer present that we didn't detect on just a small biopsy. So PAP and HPV screening is now recommended to start at age 21 and is recommended to be every 3 years. And starting at age 30, it's also recommended to have HPV testing. And if you do combined, then it's every 5 years. And this is done until the age of 65, as long as your PAP tests are normal. So there is certainly a push now also to start doing HPV only screening and then do a reflex or a follow-up test with a Pap test. And that's something that is currently being worked into the cervical cancer screening guidelines. The Pap is certainly good for cervical cancer, but there's no routine screening for other HPV-related cancers. And so the other option that we have to prevent cervical cancer is HPV vaccination. So the HPV vaccine is smart that it can hide easily in that superficial layer of the cervix, but it doesn't really go into our bloodstream. So we don't develop the same response as we would do to, say, a viral cold, where it goes through the bloodstream and our immune system can pick this up and start making antibodies. The HPV doesn't do that. So that's why when we give a vaccine and we inject those antibodies that are on the virus, then our immune system can recognize it and start making those antibodies. And so this is called humoral immunity, and it prevents infection. So as soon as then HPV cells get detected, these antibodies that we've already pre-made can start attacking it rather than getting a full infection and trying to clear the infection. So prophylaxis before getting exposed, and there are also some options for this as part of therapy for cervical cancer. So the CDC recommends the HPV vaccine at age 11 to 12, and depending on where you live, the national coverage average is about 60%, and per state, it varies largely. So you can see that California is doing really well with more than 70% of eligible children vaccinated, but other parts of the country are not doing so well, and we can certainly make some improvements here. This is another graph. So here you can see at the beginning when HPV vaccine was routinely recommended, and that was in 2006, a very low percentage of girls, and certainly none for boys yet, were vaccinated. And as time has gone by, a larger percentage of girls have been vaccinated as well as boys. And the number of children that have received at least one dose is a lot higher. But we need to see this line going up more. So is HPV vaccination effective? Yes, it is very effective. The early vaccines had either just the HPV 16 and 18 dose. Remember, those were the ones that caused 70% of all cervical cancers, as well as HPV 6 and 11, which are the cause of genital warts. The most recent development is the 9-valent vaccine that includes 9 different types of HPV viruses, and so a larger coverage. And you can see that these are very efficient in when given to HPV naive children. With almost 98% efficacy up to 100%, meaning that it can protect against precancer cells and cancer in the future. The 9-valent is a little bit younger, so the most up-to-date research is now about 98% efficacy 6 years after you've been vaccinated. So the goals of vaccination are vaccinating prior to exposure, just as we do with flu vaccines. You want to get the flu vaccine before you get exposed to the influenza virus so that you can protect yourself and defend yourself against it. It is recommended, again, for children age 11 and 12, but it's approved for age 9 to 26, and that should be the range that insurance also will cover for it. The 9-valent HPV vaccine is currently recommended by the Advisory Committee on Immunization Practices, or ACIP. And catch-up vaccination can still be beneficial. So if there are people that have not been vaccinated but still fall between, are still under 26, you can still get the vaccines. It is also approved for males aged 9 to 26 for the prevention of genital warts, and likely also for prevention of these other HPV-related cancers that we discussed earlier. So if you're vaccinated at age less than 15, only 2 doses are needed at time 0 and then 6 to 12 months later. If you're vaccinated at an age older than 15, 3 doses are still needed, and that is time 0, 1 to 2 months after your first dose, and then 6 months again. It can also be given to breastfeeding mothers, age less than 26, but not to women who are pregnant. It reduces the risk of anogenital warts, anus, penile, cervix, vulva, vaginal cancer, mouth and throat cancer, or pharyngeal cancer. And in the first 4 years after approval of the vaccine in 2006, the amount of HPV infection already decreased by 56% in teen girls. And if we look around the country, and in countries such as Australia, where the HPV vaccine is part of school vaccinations and there's much more uptake, they've seen even larger decreases of HPV infections. So in conclusion, cervical cancer is very common worldwide, although it's becoming more rare in the United States. 99% of cervical cancers are caused by human papillomavirus, and each year 14 million HPV infections are seen in the United States, with over 27,000 people developing HPV-related cancers each year. Prevention can be done with screening, with a Pap test and HPV testing, as well as with HPV vaccination. The 9-valent HPV vaccine is recommended for children aged 11 to 12, but still approved until 26, and it is very effective. So please all consider getting everybody vaccinated. Thank you very much for your attention. I'll be happy to take any questions.
Thank you, Dr. Bacchus, for a wonderful overview about cervical cancer prevention and a discussion about the vaccination. A couple of questions have come in already, and I'll pose the first one for you. You talked about the benefits of vaccination to prevent HPV. Can you touch a little bit about the risks of the vaccination so parents can make good informed choices?
Sure. Yeah. So the biggest risk is pain at the injection site. So it's recommended actually that when you get the vaccine that you lay flat, because they also seen some young children faint after getting the vaccine, because it's just a little bit more discomfort at the injection site than most other vaccines. But that certainly is the biggest risk. So laying down for the vaccine and laying down for a few minutes after till strength is regained, if you were to have any, and certainly not everybody has these problems, it helps a lot with that.
And then another question was, if I already know I have HPV or someone in my family already has HPV, what's the increased risk for developing cervical cancer?
It depends on what kind of HPV you have. So like I mentioned during the talk, there's many different types of HPV, some that are associated with cancer, some that are not. So if you have one of those high-risk types, again, it depends on if it's 16 and 18, because those have that higher risk of about 13 to 17% chance of developing cervical cancer after 10 years, or precancer cells. With the other oncogenic types, so the other high-risk types, that risk is maybe 3 to 5% or so. So it all depends on which HPV type you have and whether it's cleared. If you have a family member who has HPV, that does not necessarily put anybody else in the family at risk. This is a sexually transmitted disease, but again, most people are exposed during their lifetime. 85% are exposed during their lifetime to HPV. Unfortunately, most people clear it and build up immunity.
Okay. So two kind of follow-up questions to that. One is the ongoing screening or monitoring any different if somebody has already been diagnosed with HPV, or is that about the same as if somebody who is just having normal screening?
That also depends on if you had HPV, which type it is, and if it has caused any abnormal cells already. So there's a lot of different gradations of abnormal cells or abnormal pap test, from very minor changes where we just kind of see the HPV effect to where there's truly precancerous cells. So when we talked about that CAN3, it goes 1, 2, 3, and then cancer. So you may have CAN1, which requires a little bit closer follow-up, but CAN3 definitely is going to need action with biopsies and likely an excision of part of the cervix to make sure there's not cancer there already. So, so again, it depends on the type and what it has caused at that point.
Okay. And then another question was, you talked about HPV being a sexually transmitted disease. If I have HPV and I am pregnant, can I pass HPV to my child during childbirth?
Yeah, that's a really good question. We don't think so. However, if there are warts there, like either cervical warts or a lot of vaginal warts or on the vulva even, and their close relationship, in that case the viral burden or the viral load is much higher when it's already caused problems with warts. And in that case, yes, there is a risk that you could pass that on and have usually that then can develop into laryngeal vocal cord warts for the baby. So if there's warts, then sometimes, depending on the amount of it, and we are talking about usually when this is very bulky, then a C-section may be recommended by your doctor. Okay. But just for having a history of HPV, no, that is not a reason for a C-section.
Okay, thank you. And then one last question. If a woman has already had a hysterectomy for other non-cancer reasons, are they still at risk for cervical cancer?
No. Well, I would say no. If you've had a hysterectomy that includes the uterus and the cervix, you're not at risk for cervical cancer. If you had a hysterectomy, but they left the cervix, and we call that a supracervical hysterectomy, then you still have a cervix but not a uterus, and you would still be at risk for cervical cancer and would need to continue pap test and cervical cancer screening. So if you've had a hysterectomy and never had any abnormal PAPs or cervical cancer screening before the hysterectomy, then you can stop with having pap test because the risk is so extremely low. But if you've had abnormal pap test before the hysterectomy, and you know that you had HPV in the past and have a hysterectomy, then you could still have a some HPV infection of the vagina. So in that case, we would recommend continuing with cervical cancer screening, but really it's for vaginal cancer screening in that case.
Okay. Well, we are about 45 minutes now into our webinar, so we're going to wrap it up now. If folks still have questions that they want to pose after the webinar, you can send them along to us, and we will try to get those questions answered for you. Again, those of you who are working at sites that have access to CancerBridge, you can also call our 1-800 number and speak with one of our nurses who could answer some additional questions for you. And as Cindy said at the beginning of this presentation, it has been recorded, and we will have it out on YouTube within the next several days. So thank you very much, everyone, for your attention. Thank you, Dr. Bacchus, for a very informative webinar and discussion of cervical cancer and its relationship to HPV. Everyone have a really great day, and thank you for participating.
Thank you.